Good evening, everyone, and thank you for joining us for our combined Ruth Jackson Orthopaedic Society and Orthopaedic Trauma Association webinar, Mind the Gap, Addressing Confidence, Imposter Syndrome, and Perfectionism in Surgical Training. My name is Julie Samora, a pediatric hand surgeon in Columbus, Ohio at Nationwide Children's Hospital, and I'm also the current Ruth Jackson Orthopaedic Society president. I have no disclosures relevant to this presentation. I would like to take a moment to thank Deborah Meyer and Carrie Mink for their service and assistance and expertise and administrative abilities and allowing us to do these types of activities. The objectives for this evening are to be able to understand and define the Dunning-Kruger effect, as well as imposter syndrome, to recognize those patterns of thoughts and actions that contribute to a confidence gap in our orthopedic training and work environment, to gain knowledge on how to build confidence not only in ourselves, but also in our trainees and even our colleagues. And finally, to be able to create a welcoming, supportive, and inclusive environment in orthopedics and to minimize confidence gaps. Starting us off this evening is Dr. Heather Valliere, the 36th president of the Orthopaedic Trauma Association and the first female president. She is professor of orthopedic surgery at Case Western Reserve University and also serves on the executive committee of the Major Extremity Trauma Research Consortium. She serves as the deputy editor of the Journal of Orthopedic Trauma. Tonight, Dr. Valliere will describe how mentors can play a role in reducing gaps in confidence and minimize imposter syndrome. Dr. Mara Schenker is Associate Professor and Director of Orthopedic Trauma at Emory University. She is also Chief of Orthopedics and the Medical Director of Surgical Informatics at Grady Memorial Hospital. Dr. Schenker will discuss her personal experience as a world champion athlete and surgical trainee and her own struggle with imposter. Dr. Kathy Vu is Chief Resident at the University of Washington and will be pursuing a hand fellowship next year at Duke University. Dr. Vu will provide a perspective on how imposter syndrome and perfectionism affected her orthopedic training. Dr. Janice Bonsu is a recent graduate of The Ohio State University College of Medicine and will be embarking on her orthopedic training at Emory. Dr. Bonsu will offer anecdotes on her experiences with confidence gap as a medical student. And our final speaker prior to our panel question and answer session is Dr. Christie Weber, Vice Chair of Faculty Affairs at the University of Pennsylvania, where she also serves as the Abramson Family Professor in Sarcoma Care Excellence and the Director of the Sarcoma Program. Dr. Weber was the first female president of the American Academy of Orthopedic Surgeons, also a past RJOS president. Dr. Weber will discuss how effective leadership can help to craft a supportive environment and can minimize imposter syndrome and enhance confidence for all. I'd like to start with a brief background. David Dunning and Justin Kruger are social psychologists who published a landmark study in 1999, which has since become known as the Dunning-Kruger effect. What they describe is that college students performing in the bottom quartile provide the most inaccurate and inflated self-assessments, while those high performers actually underestimated their performance. Dunning and Kruger describe illusory superiority, which is a cognitive bias where people of low ability have an inflated sense of their abilities due to an internal illusion. That is, they can't recognize their own lack of ability. People of higher caliber, on the other hand, underestimate themselves due to an external misperception. Subsequent studies have demonstrated that poor performers struggle with accuracy of metacognitive insight due to falsely elevated high self-esteem and high confidence. Interestingly, top performers also struggle with making accurate self-assessments due to the opposite problem, They underestimate their abilities relative to others. That is, they perceive others as better than themselves. In general, we don't do a very good job of assessing our own abilities, skills, and knowledge. It's been shown in many studies, whether assessing logical reasoning, grammar, or evaluation of our own competence, that those in the bottom quartile routinely overestimate their own skills. Observers' ratings of an individual's skills and personality traits are far more accurate predictors of job performance than any self-reported scores. In 2006, Davis and colleagues published in JAMA, physicians who were the least skilled were also the most confident. This finding should give us all pause. I'd like to take a moment to review this graph. On the y-axis is confidence. On the x-axis is competence and knowledge. And at the early stages of the Dunning-Kruger effect, those with fairly little competence and little knowledge have high confidence. But as the competence and knowledge increases, that confidence actually goes down. Our goals as leaders, surgeons, and educators should be to reach this slope of enlightenment, where not only do we have high competence and knowledge, but we also have high confidence as well. It has been suggested that perhaps this phenomenon explained by the fact that top performers also tend to have perfectionist traits, such as setting extremely high standards, having high internal motivation, and being quite self-critical with any perceived failures. And although this self-criticism is a process involving harsh scrutiny and evaluation of oneself, which can lead to personal growth, this habitual self-criticism has been shown to result in lower self-esteem and lower self-compassion. That brings me to the concept of imposter syndrome, which is a psychological pattern in which an individual doubts their skills, talents, and accomplishments, incorrectly attributing them to luck. Persistent internalized fear of being exposed as a fraud is a feature of imposter syndrome. And imposter syndrome has been shown to affect both men. I like this figure, where the types of people who can have imposter syndrome are shown on this pie chart. And it's really all the smart, successful people that you think have their stuff together. And although anyone can have imposter syndrome, perhaps it has been suggested and shown that there are, gender-based differences in self-criticism, self-esteem, and self-confidence. Females self-report lower scores than males in IQ, in general, musical, mathematical, spatial, and business intelligence. In adolescence, females rate themselves as less scientifically talented than males, and this gender gap increases with increasing age. And there is no correlation with differences in actual ability. In college, female students rate themselves more negatively than male students in scientific reasoning, without any actual differences in ability. In medicine, female medical students tend to underestimate their abilities, and males tend to overestimate their abilities. And despite performing at an equal or even superior level to male medical students, female medical students consistently report more anxiety about their performance, greater stress over their competence, and less confidence in their abilities than their male counterparts. We performed a systematic review and found that 24 of 31 studies showed that males tended to rate themselves higher than females, whether it be in clinical knowledge, basic skills, procedural confidence, or operative experience. Imposter syndrome, stress, and burnout was higher in women than men. And there were no objective differences in performance or skills at any level. In summary, the Dunning-Kruger effect demonstrates that low performers tend to overestimate their abilities, and high performers tend to underestimate their abilities. And perhaps this effect may explain why those with high skills and knowledge may lack confidence and exhibit imposter syndrome. Illuminating the disparities that exist, whether it be in self-confidence, self-efficacy, imposter syndrome, or other factors, can help to develop tools, programs, and support systems to minimize these differences. With that, I would like to turn the mic over to Dr. Valliere. Thank you. While Dr. Valliere is pulling up her slides, I would like to remind everyone in the audience that you can put questions in the chat box, in the Q&A box, and we will answer them toward the end. Also, you were given a survey. If you fill out that survey, we would be very grateful, and we will share the results with everyone once we have the combined results.
Good evening. I'm Heather Valliere, and I'm really grateful to have this opportunity to engage in this webinar this evening on such an important topic. I thank the Ruth Jackson Orthopaedic Society for sponsoring this, and it specifically also thank Dr. Samora for her leadership in developing this webinar and for inviting me. I have no disclosures relevant to the content of my presentation. So we're going to talk for a few minutes about role models and mentors and look at some ways to reduce that confidence gap that we just learned about. You've heard some from Dr. Samora about the Dunning-Kruger effect. Again, to reiterate, those with higher ability and aptitude frequently underestimate themselves. Happens in women and men, but more often in women. Conversely, those with less ability tend to have an inflated sense of self. Being surrounded by this illusory superiority can further erode our self-concept and our confidence. Imposter syndrome is also commonplace amongst women, and much of that may have to do with working in a male-dominated field like orthopedic surgery. There's a lot of new information coming out about this. In fact, last month, I noticed at the AOE meeting, Dr. Schenker, one of our upcoming speakers, and her colleagues had a poster denoting the effect of imposter syndrome among orthopedic residents. At the end of the day, these issues contribute to a substantial confidence gap. What I'm going to challenge you all to do is to not let it be a self-fulfilling prophecy. So my challenge then is to determine some ways to reduce the confidence gap. And I hope that at the end of this session, you'll be able to walk away with a couple of ideas to develop more confidence in yourself. First, by learning about this effect, the confidence gap, and committing to your surgical education and professional development. You all are doing that as being present tonight and being engaged in your professional path. Your surgical education and training, getting more experience, more knowledge, developing more relationships are all going to improve your familiarity and confidence. These practices will also broaden your professional network and opportunities. It's also very important to get constructive feedback. At times, this can be painful. We all have strengths and weaknesses, but in order to commit to professional development and growth over time, it's very important to pause, reflect, especially when things don't go as planned. How can you grow as a person? How can you improve your skills? One way to do this is to identify role models and mentors. I share with you in a very abbreviated way just a few personal anecdotes to help you recognize that we all experience these issues. And I can say that the confidence gap used to be a problem for me along my pathway. And I've learned some ways to identify it and to move on and to develop appropriate level of confidence and self-reflection. When I started out back in school as an undergraduate, I frequently heard oh, you're just getting lucky. Even some of the people listed here, not by name, by category, often had not constructive things to say about my lack of suitability to be an orthopedic surgeon, or potentially to be a wife or a mother, that probably wasn't going to work out. I found this disparaging and very detrimental to my confidence at the time. But one way to counteract that is to identify role models and mentors who can be a powerful driving force and help you stay on track with your professional path. When we think about the definitions of role models and mentors, these are really different types of roles that they'll function in. And a role model might be someone who has character traits, a career path, life experiences, which you respect and may aspire to. A mentor can be a role model, but is much more than that. These are some of the people who were mentors for me along the way. Yes, they're all white men who are older than me. The nature of the field that we practice in. Yet each of these individuals was so helpful to me, so powerful in helping me to learn more about myself and to advance to the next level. I sincerely acknowledge their contributions and I'm very grateful for the relationships that I've had. I think that in a field that's been dominated by men, and particularly by white men, many times we might feel frustrated to not have a mentor that shares our own ethnic, gender, or other preferences, and that's okay. As we grow in diversity, the opportunity for mentors with various backgrounds will become more common, and there are many wonderful people who are capable of functioning and aspire to be strong mentors, irrespective of some of the personal traits that we can't change about ourselves. So along the path, I was fortunate to have many mentors who gave me encouragement, helped me develop confidence, gave me constructive criticism, and challenged me in ways that I was able to push on to the next level. How do you find a mentor? Well, you've probably, by observation, seen people that you've worked with, maybe a senior resident or a fellow, maybe a new faculty member who you think their behavior, their style, their personality resonates with you. You have common goals to what they've accomplished in their career path. Maybe it's through word of mouth. You confide in a friend, a colleague, a faculty member who can acquaint you with someone who may be a suitable mentor for you at the time and place that you're in. There are also academic lists through various medical schools, orthopedic programs, and through professional networks. For example, the Ruth Jackson Society has a mentoring program. I hope some of you are already involved in this. It's an opportunity for you to share a few characteristics about yourself via the website, register as a mentee. And likewise, there are people within the Ruth Jackson Society that have self-identified as wanting to be a mentor and to have relationships. And so mentors and mentees are paired up based on those characteristics. It's a wonderful way to start to engage with an orthopedic surgeon. The Orthopaedic Trauma Association has a mentor program too. This program is very specific, though, for development as a researcher. And it's whether you are interested in clinical or basic research or both, perhaps to give you feedback about papers, about grant proposals, about developing a research program. And so it's a little bit more of a specific mentorship program, but it's something that may be very valuable to you depending on what goals you aspire to. So once you've identified a mentor and approach them to engage, we're going to talk a little bit more about defining expectations for the relationship, understanding that these relationships tend to have their own life cycle, which will depend on you in this situation and that relationship. Hopefully, opportunities for professional growth will happen for both the mentee and the mentor, allowing for reflection. And ultimately, most of these relationships will experience some disengagement over time as you grow and as you age. And doesn't necessarily mean that you don't have any communication with that person anymore. Perhaps it does, but not necessarily. I think that some of the keys to success in any of these relationships are to be very intentional about it and to establish clear expectations and ground rules. People seek a mentor for a lot of different reasons and at different times in their path. And some of the reasons may overlap in time and purpose, but if you're clear about communicating with a potential mentor as to what your goals are for yourself and for the relationship, I think that shows maturity and clarity of purpose, which is really setting a foundation for a good relationship. Hopefully that results in a mutual level of understanding. Honesty is very important, and sometimes that can be really brutal because we do all have strengths and weaknesses, and it's important to identify weaknesses and areas for improvement or areas to step away from at times if a certain goal or portion of your path isn't going as you anticipated. There may be times when the relationship demonstrates conflict, and it's okay to disagree. It's healthy to be honest and to have areas where you don't always agree. Recognizing that both you as the mentee and your mentor will continue to grow together and will change over time. Leads me to the point again of determining when to disengage. And this is very situational. It may depend on as you move into the next step of your career path, geographically, temporally, or otherwise. And then another important point is to not really overstep within the relationship. And this can be both ways, setting some ground rules about that. Very important to be respectful of each other. I share with you a list of traits of a highly effective mentor. I credit the Academy's Orthopedic Educators Workshop. I've held on to this list because I think it's really a good one that is helpful for mentees to look for in a mentor and helpful for mentors to aspire to be accepting of individuality, different starting point, different characteristics. We are all unique individuals with a variety of talents and different aptitudes. Effective mentor will be able to share knowledge completely and unselfishly, and to be encouraging and supportive, but as I stated, constructively critical. That's the way that you'll really get better at what you do. It's important to set the bar high, but to have some rest points along the way. I think this is one that is easily forgotten, I know for myself, but one that's very important to be sustained in your path. An effective mentor will also have a secure ego with her own role and accomplishments, yet share in your challenges and quests, and at times offer collegiality. This again is very dependent on the individuals and the situation, and there may be some situations which one member of the party or the other considers an overstep, and that's why it's important to have honesty and clarity of communication. Effective mentors also derive wonderful personal satisfaction from mentee accomplishments and look forward to the succession planning of the next generation. So I hope each of you will have mentors, if you don't already, and can be a mentor too, because what you leave behind is not what is engraved in stone monuments, but what is woven in the lives of others. I like this quote a lot, and I think it's very relevant to the discussion we're having this evening. I hope that you'll all be able to take what you've learned, not just from this session, but through your professional path, and to pass it on, pay it forward, and remember that you have a legacy and lasting impact too. All those times that you feel unconfident and consequential, you too are making a difference. Thanks so much for your attention. Have the pleasure now of introducing our next speaker, who will be Dr. Mara Schenker. And she's going to talk on the intersection between performance psychology in sports and surgery.
Hi, good evening, everybody. Thank you so much for the invitation to be a part of this really outstanding group. And this is something that's near and dear to my heart. I actually give a very similar talk every year to our residents, and I've written a bunch about this. And so I'm just going to use this as an opportunity to sort of share my story. I've had so many emails in response to some of the Kevin MD articles that I've written, and I know this is something that is a big issue, particularly for women in surgery. And so I'm just going to tell you my story, and I'm happy to answer any questions along the way. And so this was me. So I started martial arts when I was 4 years old. I don't remember what it was like when I started martial arts, but I continued to do it 6 hours a day, 6 days a week for all the way through part of medical school. I, in 2001, won the world championships. And while this was such a huge moment to me at the time, I look back on things. And when I was sitting at the world championships in 2002, I can very distinctly remember looking around. So I won in 2001, this is in 2002. And I can remember sitting in the ring, and we used to wear these special uniforms that said world champion on the back. And I looked around, and I was, 19, 20 years old. And I looked at everybody around in the audience, and I was like, or everybody in my ring. And I was like, these people are all better than I am. They're all world champions. And I remember looking at the years on the back of each person's uniform, and I'm 20 years old. And it hit me, and I was like, well, you're the most current world champion. You belong here just as much as anybody else. And I didn't have a name for it at the time, but that was my first recognition of imposter syndrome. I was the current active competing world champion, and I didn't feel like I belonged there. And so then fast forward, after I decided to change careers, and I show up in surgery, and the same exact thing happens, except for at this time, you're not 4 years old when you start to learn how to be a surgeon. You're a full-grown adult who teaching a full-grown adult how to do a technical skill is not exactly an easy thing to do. And so I can tell you, when I started surgery, all of these things were going through my head. And I think, maybe they don't go through everybody's head, but I know they go through a lot of people's heads, because now that I teach a lot of trainees, I've had this conversation many, many, many times. And so it goes through your PGY1, PGY2, PGY3, and you're like, I don't know anything. Like, I don't belong here. I can't do anything. What's it like when you first pick up a drill and don't know how to use a drill? But then I got stuck personally in I don't want to make a mistake. I need to be perfect. And if that part of the whole imposter syndrome, perfectionism cycle is vicious, because you don't want to make a mistake. But imagine learning how to walk and never falling, or same thing in Taekwondo, never making a mistake in Taekwondo, you're never going to get better. Surgery is the same thing, but then at this point, you add on top of that, you're an adult and you're afraid to make a mistake and you want to be perfect. And then what's running through my head at the same time was, I've been good at something before and I'm not good at this. I like to be good at things. And am I going to get better? Do I belong here? And this is what was going through my head when I was a resident. And I can assure you, if there's anybody who's on here who's my prior mentor in residency, they probably didn't know this. I was good at administrative tasks. I was good at research. I was an administrative chief resident, but I felt like my technical skills were behind. And so I was stuck in this vicious spiral for many years. And so looking back on it now, sort of, from a 30,000 foot view, I realized a lot of this was in my head. Some of it wasn't. Some of it was told to me by people who were ahead of me, but most of it was definitely in my head. So I hit a critical point at my PGY4 year. I can remember where I was standing. I was standing by a window outside an operating room, and it hit me. I was like, I'm not meant to do this. I either need to figure out what my problem is and I need to get better, or I need to find something else to do. And it just sort of hit me. And at that point, I also realized that this was exactly the same thing that I had experienced when I was competing in martial arts. I was sitting there, I was like, I belong here just as much as anybody else does. I worked just as hard as anybody else did to get to this point. And I'm here and I need to figure out what my problem is so that I can continue to get better. And so analogy between my life in sports and my life as a surgical trainee was very analogous. The only difference was I was now 3 decades older than when I started martial arts. And so I think that once you get into that inner dialogue and you get in your own way. And so I decided at that point, yes, I did need to make technical skills improvements, and I decided that I was going to do it one step at a time. And that crossroads was legitimate. I was either going to move on to do something else, or I was going to take baby steps to get better. And that's what I decided to do. And so I started to read about this, and a lot of the review articles and stuff that I've written are about how I sort of tackled this myself. And I started with this article, and it's Managing Oneself by Peter Drucker. If you haven't read it, it's something that's very good. It's good to do it every single year, but go through what are my strengths? What are my weaknesses? How do I work best? And what are my values? And where do I belong? And ask yourself that on a yearly basis, because your weaknesses change, your strengths change. If they don't change, you're not growing. And you should always have weaknesses that you're working on, and be honest with yourself. And so this is I actually still have a copy of it from when I was a resident. And if you look specifically at what are my weaknesses, I was very honest with myself. So my weaknesses were confidence. I felt like I needed to do things perfectly in order to feel like I was able to do them. I took every bit of criticism personally, and that got in my own way. I didn't take feedback well. I didn't give feedback well. And I also felt like I was technically behind. And, I would argue that I was technically behind, knowing who I was back then. But I was very, very conscious about how to make improvements to make that better. And so I treated, I needed to learn how to fix fractures, ankle fractures, hip fractures, femur fractures, proximal humerus fractures. But I also treated confidence, perfectionism, and feedback as skills that I needed to learn. And I read and read and read. I read just as much as I did about orthopedic trauma. And now I read more about stuff like this. And probably the most important book that I read was when I was a PGY4, and it was The Confidence Code, which is in the bottom right. And that's something that if you have any issues at all with this, it's an outstanding book, and I would highly recommend it. And so these are also very good. The Confidence Gap was in The Atlantic, and most of these articles that I'm referencing are all in the lay press. The Paradox of Excellence, which is the middle one, and I'm happy to share my slides, but that one I still read over and over again, and that's in Harvard Business Review, and it talks about how high achievers often undermine their leadership by being afraid to show their limitations. That was me. I don't know why we don't talk about this in medical school. I don't know why we don't talk about this in surgical residency. I don't know why we don't talk about this in real life, but it's not something that I ever really learned. And it's something that I sort of taught myself along the way. And so one of the other things that I did is I put myself in the fire. I knew that I needed to be busy and be willing to make mistakes, and being forced to make mistakes and drink from a fire hose. So I chose to go work at Grady. Grady was not somewhere that my fellowship had recently wanted to send people. And it was a risk that I took when I went there. And it is the best decision that I have hands down made in my entire life, because it forced me to do a lot of surgery, and it forced me to make mistakes, and it forced me to get better. And now, as of about 3 months ago, feels like 6 months. As of about 3 months ago, I took over as the chief of orthopedics for Grady. And I've 20 faculty, something like that. And it's an amazing experience. And I would not trade that high volume for anything. And so I've written about this, if anybody has seen it, but why intangible skills, so confidence, perfectionism are important for surgeons, and what is good enough for a surgeon. These are some of the articles from Kevin MD. I have gotten a lot of emails from students and trainees and faculty around the world who've identified with this. So if you identify with this, you're not in the minority. What I think is very interesting about all of this is that there is an entire field dedicated to sports psychology. So how do you become a better athlete? And their characteristics of the athlete, the training and the practice, and the social environment. We don't have anything like this in surgery. We don't talk about the mind game behind how to improve. We don't talk about how to really mentor someone. Dr. Valliere did an outstanding job on this, but it's not something that I felt fully equipped, other than when I opened my story and other people said, "Oh my God, that's me too." And then I just gave them a bunch of things to read. But I think we have a long way to go with optimizing performance in surgery. Like surgery is a hard thing to do. And so what I would ask is that we normalize this conversation, and this webinar is absolutely hands down the first step to that. We need to teach our trainees that everybody learns differently, everybody copes differently, and that's normal. We need to leverage existing mechanisms. People have done this before. Sports psychology is an entire field. We need surgery psychology, or we need to bring the mind game into how to teach people how to be good surgeons. And then force yourself into uncomfortable situations. You're not going to get better unless you force yourself into uncomfortable situations, or at least I wouldn't have. And that's as a trainee, that's in practice, and that's in life. I'll continue to put myself in difficult situations because that's the only thing that's going to make me better. And then I can assure you it does get better. One sign of whether my technical skills have gotten better is that the anesthesiologist, the radiologist, if they send their family members to you, that's a good sign. And so I think that despite coming in feeling like I wasn't good, I think I've gotten there. And I think I can always continue to get better, but it's definitely something that I've worked at. It's not something that's come naturally to me. Thank you.
All right. Hi, everybody. I'm Kathy Vu, one of the chief residents at University of Washington. I want to say thank you for the faculty for including me in this panel. And I hope to just share some of my perspective from my time as a resident here in this discussion of confidence and imposter syndrome. So during my time in residency, these were some of the common thoughts and whispers, maybe sometimes screams that circulated. I don't think some of these are unique only to female trainees, but I do think that they disproportionately occupy our thoughts. I wish we were in person to see how many people would actually nod their head to hearing these because they're all too familiar. The times when we've been overlooked on rounds and said patients defer to the male figure in the room, who's a med student who then fearfully look back at you for help. Or the times when we've been hesitant to speak up during conference unless we're 100% sure of the answer. And at the same time, always kind of doubting our knowledge base, thinking our co-residents know so much more than we do. And the times of hearing how Joe, apologies to the Joes out there, who did the entire case himself and feeling like we're not progressing or performing at our expected level. And even when a case went well, I think we often retrospectively review and fixate on things that went wrong. And so if you've ever had any of these thoughts, I want to just emphasize, especially to the junior residents out there, that you are not alone in any of this. And so I'm hoping to learn from today's webinar from these leaders in our fields that pave the path of how do we change this mentality. My contribution here is just from reflecting on the last few years of residency and thinking about what I would tell intern year Kathy. So first thing I would say is to set the stage. I had one attending who told me at the start of residency to not be afraid to introduce yourself as a doctor. I sometimes, I think, hesitate because I don't want a prefix to become this barricade between me and the patient. But ultimately, she was right in that I needed to say it since it was my credential, and it helps to really establish my role in the team and also with my patients. Sometimes I recognize that my lack of confidence may stem from the constraints of certain situations like the time pressures of clinic or the operating room. And while I think that we all need to learn how to perform better within these parameters, I don't think it hurts to be a little bit more prepared while we're still in training. And I find that prepping for clinic, for example, at the beginning of a new rotation helps jog my memories. It allows me to really think through some of the patients before the visit if possible. And as I see more and more of the patients, it becomes a pattern and a pattern recognition activity, and it goes a little bit easier. Similarly for the operating room, and this is one area where I still strive to do better, but I think creating an operative plan, discussing it beforehand with your attendings, gives you the time you need to really demonstrate your knowledge and your thought process. It also gives you an opportunity to convey your goals for a case and provides more tangible metrics to determine your progress. I think there's also no better way to really work on building confidence while being a trainee than learning how to be a better teacher. So I think it helps reinforces your knowledge, since you have to know the material and know it well enough to teach somebody else. It also introduces this element of being comfortable with being questioned, and either being okay with saying you don't know, or really allowing you to assert yourself with a relatively low risk environment. And ultimately, I think it also goes to remind you of the fact that you know more than you give yourself credit for. This guy here on the left is the French philosopher Diderot, who gave us this quote that skepticism is the first step towards truth. And so I think the proclamation we often hear of co-residents, quote unquote, completely crushing a complex case can use a little dose of skepticism. If there's anything I realize at this point in training is that attendings are literally wizards. They can probably make a first year med student feel like they anatomically fixed a complex pilon fracture independently. So I think it's important to be wary of this narrative and not let it become a seed of doubt of your own ability. And lastly, I think we can all do better to start modeling the behavioral changes. So as we move through the years of training, we'll have more junior residents. So I think it's important to be cognizant of how we talk about performance. We can be critical to improve, but also acknowledge aspects that went well. I think we should set up the junior residents for success. Sometimes it's a little bit of behind the scene coaching by either reviewing cases with them beforehand, and other times it's a little bit of tough love, call on them, show them that they have what it takes. And finally, but most importantly, I think we should be open about discussing these challenges. I think everyone believes that people have moments of struggles during residency, but at times there's this pressure to display perfection that becomes isolating. I know I, for one, internalize it and think maybe it's just me. So having a forum like this or within your programs where you can talk with your co-residents, with your junior residents, I think will help remove the stigma from confidence issues and hopefully strengthen each other. Thank you for your time.
Hi, everyone. I'm Janice, and very grateful to be on this panel with everyone. I'm going to talk a little bit about the trainee experience of confidence and the confidence gap. So I grew up in an immigrant community, and we were all told that we had to be twice as good to get half as much. So even when I met the bar one-to-one, I still felt inadequate. And this was just the beginning of a long journey for me and my confidence gap. And it manifested itself as anxiety whenever I was faced with any large decision. Should I run for student government? Where should I go to medical school? What should I do for residency? And I remember being paralyzed by this decision of which specialty I should pursue back in December. And I felt like I just didn't fit the bill of ortho, and I couldn't find anyone who I identified with to help guide me into the field. But serendipity led me to meet a female ortho attending at my College of Medicine. And she pulled me aside after a talk and she said, I don't know what you want to do for residency, but here's why it should be ortho. And I had never told anyone that I was interested in orthopedic surgery. And for the first time, someone looked at me and saw that I could do it. So she, along with the other female and male attendings at my university, began to mentor me academically, but also critically in building my confidence. And 2 months ago, I was just a medical student, and now I'm just an intern. And the impact of my training status on my confidence is real and important. As a trainee, my confidence manifests itself in never accepting positive words about myself, taking criticism very personally, things we've heard today, needing to double or triple check something before I commit to it, not raising my hand for opportunities, and most importantly, not being able to move on and let my mistakes go. So it's been important for me to recognize how much I have left to learn, but my mentors have been helping me realize how far I've come, the skills I have attained, and the knowledge that I do possess. So for me, the lack of knowledge because of my trainee status and experience leads itself to lack of confidence, which keeps me in inaction. So we have to close the confidence gap, right? I've been told the secret to success is both competence, knowing your stuff, and confidence, which is believing in yourself. So what's in our hand as trainees is the competence angle. For me, this means I'm at this desk putting in the hours to improve myself academically and also in the OR technically to be a good orthopedic surgeon. But that's not enough to get me to success. There are still the social aspects of my confidence that can threaten to hold me back. And that's where mentorship comes in. My mentors told me that confidence is not the absence of doubt. It's acknowledging your doubts, but believing that you're capable anyway. And it's a variation of the fake it until you make it that's a little bit more responsible. For example, they've modeled that, what not to do is be overconfident and cut people off, never accept responsibility, someone who can't manage their emotions and walks away in a huff. And they've also showed me what I should do, what other trainees should do, which is be calm and relaxed, be knowledgeable about every team member's roles, be aware of your body language, be thoughtful about your actions and when to admit your limits. And these are some of the things I've learned so far. I'm learning so much more still. Unfortunately, society raises us in ways that we cannot help, and it takes shots at our self-confidence. So as residents and trainees, we must work on what's in our control, the competence, the academic and technical knowledge, and lean on our mentors and colleagues as we continue to build that confidence to get us to success. So thank you all, and I'd like to pass the mic to Dr. Christie Weber.
Can you see that or?
Not yet, Christy.
Let's see. How's that? Does that work?
Yeah, perfect.
Okay, great. Well, thank you very much, Julie, for inviting me. I really appreciate all the other speakers. Learned a lot from each talk. So I am batting cleanup. Christie Weber. Want to talk about leadership and the confidence gap. And this wasn't as easy a set of slides to put together as I thought it might be. So my disclosures are that I have certainly had times where I have lacked confidence and I have experienced imposter syndrome. So some of this will be a reinforcement of what we've heard already. But, when I think about confidence and I look at the various residency programs I've been involved with, confidence, that's really a core issue. And Janice touched on this. It's built early. It has to do with the support and reinforcement and the pushing that you get from your parents, from your teachers, from your coaches early on. And so sometimes I think, people come in at very different levels of confidence and it makes it more challenging. The confidence gap, as we've mentioned, is both men and women, but I would say that women are much more willing to admit this in general. It occurs with anybody, no matter what level you are, as was mentioned earlier. And critical terms and concepts that we need to think about, and I think it's really important for each of us to know where we are with these particular terms. Resilience, grit, Angela Duckworth talking about talent, and effort times effort. Emotional intelligence, which plays a role here. Courage, which I think is one of the most important things, and we've heard about that tonight. It really takes courage to be confident to push through. And then I can't give a talk anymore without commenting on Brene Brown. So, that whole idea of courageous leadership instead of armored leadership requires the courage to be vulnerable. And as we just heard as well, it's normal to lack confidence at times and to be hard on yourself, to be perfectionistic. And the key thing is to recognize it, to be kind to yourself. Don't beat yourself up, to seek help in whatever way you can, and to really get your eye on the prize and visualize that success. And per Dr. Vu, you have to be open to discussing this challenging topic. So when Julie asked me to talk about leadership and the confidence gap and how leadership decreases the confidence gap, I thought, well, okay, but in order to be a leader, you need confidence. So if confidence is going to help decrease, or leadership is going to help decrease the confidence gap, you still got to get to the leadership role. So how do you build the confidence? And I think, you know, if you're talking about building confidence as a leader, it's not too dissimilar to thinking about it as a resident surgeon. So we talk about studying the skills required for leadership, and Mara touched on this as well. This is, I mean, really reading everything you possibly can about leadership. It's not just about reading, but it's critical for you to understand the key points about leadership, and then to really evaluate yourself to know whether you are exhibiting those. And this is not that much different than studying the skills for residency, whether you're working on plating a sawbone, or you're working on your suturing or your tying techniques. You really need to be excellent at those things. And those are things you can actually perfect. The other thing is preparing and knowing everything about the leadership role you're going to take. And I can't emphasize this enough. When I think about this, I think about Stu Weinstein. I happen to be on the Academy Board of Directors when Stu was the president, and he knew everything about the Academy. He read everything in preparation for his role, and he probably still knows more about that organization than anyone else. You really have to put in the time. Work hard, really hard. So leadership requires work. It doesn't require going home before the rest of the folks. It's spending a lot of time and working super hard. Being self-aware and asking for honest feedback. This is critical. 360s, just so you better understand where your weaknesses are and your limitations and what you need to lean into to get better. Seeking advice. Heather talked about role models and mentors. I would also add a coach. This picture is Catherine Morrison, a coach that was really influential for me a few years back. Really working with anybody you can to get advice on better leadership and how you interact with others. I would say this, it's not about you. And I saw this book listed on Mara's slides. You know, What Got You Here Won't Get You There, or What Got You Here Won't Get You There is a phenomenal book. And it really brought home to me the concept that when we think about orthopedics or other maybe medical specialties, to get the leadership roles, we have to really traditionally rely on our own individual CVs, how many papers we write, how many grants we get, how many awards we have. But really the leadership that we're looking for great leaders is not about you. It's about your team. It's about working with, enhancing others, leading a department, and leading a disease team at even a greater level. We're leading more than just orthopedics. You have to have the courage to leap or stretch. And this book's never far from wherever I am, Brene Brown's Dare to Lead. I mean, really putting yourself out there, having that courage to visualize that prize. Deep breath, don't quit. I'll look at Mara's pictures of her doing the Taekwondo, and I'm sure there were times where it was really hard, but you've got to push through. And then projecting confidence and or vulnerability as needed. So if you have the skills to become, the confidence to become a leader, if you lead well and you have success, it will build confidence in a stepwise fashion. So I will mention that leading well is not about just having the title. So we think about an academic chair. You think about somebody who's the head of a private practice or someone who's head of a national organization. These folks can't just sit in that chair and do nothing. We know people, probably all of us, that have done that and have just written their title on a CV, but they haven't actually moved things forward or made things in improvement. So as an academic chair, really raising others up, advantaging others for their own success. If you're the head of a private practice, you've got to be able to think strategically to move your group ahead, to innovate in both processes and technology. National organization leaders need to be able to move forward strategically and develop partnerships. Leaders are judged on how they set strategic goals, and then not only setting the goals, but what you achieve in terms of metrics and objectives. Again, that focus, that ability to have the eye on the prize and not get distracted with a bunch of other possibilities. Accepting that critical feedback is important. Really advancing the group that you're leading with a proactive stance and change management. And you still, I would say, need thick skin sometimes, because there's always going to be the folks out there that are trying to tear you down. And then finally, my last slide, I'll take my prerogative to talk about culture as I try to do in almost every talk. If you're going to lead in our field, in any field, you have to understand the culture of where you're leading. And so if you're like me and you believe that the orthopedic culture out there needs to change, then I think that as leaders, we need to take intentional steps to change that culture. We need to model the change that we want to see in the field. We need to remove structural barriers to inclusion and belonging. You know, if you're an academic chair, who gets to speak at the faculty meeting? How do those meetings run? Do people feel like they belong? Do they feel included? If you're the lead of a private practice, are you embracing flexible schedules, family leave, to be able to, again, make everyone feel included and valuable? If you're leading a national organization, process over personality. It's not about you. Evolving the governance to stay away from sort of old traditions that are not effective anymore. It really requires courage and confidence to push change in a traditional culture. And I would suggest that orthopedics is a very traditional culture. And finally, integrity, again, Brene Brown, requires you to really believe in yourself as a leader, to lean into your values, to choose courage over comfort, to choose what's right over what's fun, fast, or easy, and to practice those values and not just profess them. And I think we have to think about, do we speak up? That may be as a resident leader or a leader in the field, but do we speak up, or do we stay silent when we see things that are not as they should be? And that's all I've got. So I will stop there and we'll get on to the Q&A.
Great. Well, thank you everyone for these fantastic talks and for your honesty and your, your ability to share your personal vulnerabilities. One of the questions, and feel free, the people in the audience, to keep asking questions. One of the questions I'll direct to Dr. Schenker first, and have some of the other panelists wait. For those who train others, how does imposter syndrome manifest itself among the trainees? That is it obvious? And is there a difference between imposter syndrome and true lack of skill and knowledge? Is that obvious?
Thanks. So I would say it's obvious to me, but whether it's obvious to most people who are training, I would say the answer is probably not. I've had some of, like, when you have somebody who's having an issue as a resident, I've had discussions with some of my faculty, and someone will say that person's lazy. I'm like, that person's not lazy. Like, they're standing over in the corner with a notebook, writing down every single little thing we say. I'm like, there's some gap in the way that they're learning. And so, I mean, honestly, like, I think that it's not obvious to the majority of people who are doing the training. The signs of it, it's the only way I really dig deep on it is if I ask people, if I say, hey, like, or if I notice it, I will actually approach them and say, hey, I know it might be hard for you to put yourself in an OR a lot of times, but come operate with me. I'm going to be hard on you. I'm going to make you do things that you don't want to do, but be here and you'll get better. And I'm here to help support you. And so I think that the more we keep talking about this as educators, the easier it's going to be for people to be able to recognize it. And just hope that there's somebody in your training program who you can go to if this is you, or come to one of us.
Anyone else want to weigh in on that question?
Yeah, Julie, I'll just make a comment. I do think it's not super hard for those of us who are attending surgeons to pick that up. I mean, I think what I see is people that they know all the answers. They really know all the steps to an operation, but just are not able to get themselves in there. I know they know what to do, but it is that perfectionism. You read these articles about how men beat themselves up on the playground growing up, right? They get dirty, they get back up and they put their arms around each other and go get a beer. And, girls are sort of raising their hand, the Hermione Grangers of the class, getting everything perfect, everything right, and sort of expecting that to continue. But, the world is not easy, and you've got to be able to dig in, and the answers are not always going to be there. And I think when people come into orthopedics, people are really good students. And, in a technical field, you're not going to get it right all the time. You're not going to be a perfect surgeon right out of the bat. You've got to be willing to fail. And it's better to fail early in your first or second or third year. If you wait and then you get into your fourth and fifth year and you haven't really put yourself out there, it's a lot tougher in a residency program, I think.
One of the questions was whether or not we can share all of the books that we recommended. Absolutely, we can send an email out to the registrants and share a list of books we think are good options for you. This next question I'd like to direct to Dr. Valliere. It says, I found it very difficult to get honest or constructive feedback, even when I've sought it out. People don't like giving negative feedback, but how do you encourage someone to do so?
Yes, I would totally agree. Worked with a lot of different faculty over the years and in various settings, and it's a huge issue. In fact, it even came up at a faculty retreat we were having last month. It's not something that's comfortable for any of us to do, but it's a really important part of our roles as surgeons, as fellow colleagues and professionals, and particularly if we hold a faculty appointment or leadership appointment, because that's how we get better. And in the business of taking care of people, it's imperative that we continue to strive for excellence and that we grow, that we as a group grow, and that individuals on the team continue to be encouraged to perform at a high level. And so I think that one of the things that helped me to get better at providing constructive feedback and criticism for that matter specifically is to, first of all, plan ahead, and have some ideas as to how to do it. I tend to set a time to do it so that it's planned and it's private. It's not just in a hallway or where there's other people nearby. So there's a quiet time to have some time. And I try to lead conversation with asking that individual, what did you think about this situation? Or what did you think about your rotation? How would you assess your own performance? Now, oftentimes I have a decent idea if that person has a concept of themselves that's on track or not. And it's somewhat more difficult if they don't perhaps have any awareness of where they're underperforming. But just by allowing them to express themselves, it gives me a better idea as to how to frame the feedback. And then in delivering the feedback, I try to balance it with a couple of things that I've noticed improvement on or where goals are being met. Sandwich it with some areas that really need improvement and provide specific examples as to what those incidents are. So it's not just general things. So there's specific examples, whether it was a patient case scenario, or it's something in the OR, whatever the situation may be. And then again, wrap it up with something positive as to some ways to work on that and try to get buy-in. And then the other thing I try to do, and I'm not perfect by this on this by any means, but I try to follow up with that person like a week or two later to sort of see where they're at for a couple of reasons, just to make sure that they're on track. I didn't push them away. And if they're not improving, to actually give them a hard reminder, hey, this is still something that needs to be worked on. And I'm going to keep bothering you about it because I really care about your performance and I want to see you do well. So those are some of the things that have made it better for me. And I think with time and with practice, it's a skill that I continue to work on, but I feel like I'm getting more effective at it.
Dr. Cynthia Emery offered that she had written an article in Core actually on how to give and receive feedback. And she offered to share that with us, and we will send that article out to the group as well, which might be adding a few more pearls. So I have a really tough question here from Dr. Johnson. What role does society play in creating imposter syndrome in women, in highly educated professionals, and underrepresented minorities, and them more so than others? So anyone want to take that one on?
I think I just want to chime in as a trainee and relatively, I guess, underrepresented minority and a woman in this field too. I think it's about representation. And so, you grow up and you don't see a lot of the people who look like you and do that job. And so you start questioning, just like Dr. Schenker mentioned in her talk, like, do I belong here? Am I supposed to be doing this? And so that's where that seed starts being planted. And then throughout society too, as a female, I mean, of a relatively normal size, I would think I am, people would question, like, are you strong enough? And so there's a lot of, I think, undertones to how we are communicated to and kind of the messages that we receive that definitely perpetuate why we developed imposter syndrome as underrepresented minorities and also as females.
I would also say that, confident women find themselves in a catch-22, right? We've talked about that before. That was in the confidence code. That whole confidence, and sometimes you read these books that say, put yourself out there and act more confident, but sometimes that doesn't go across very well. As a confident woman in orthopedic surgery, sometimes your style becomes a problem to others around you, depending on the culture that you're in. So it remains a balancing act. And frankly, it shouldn't be on the woman or the whoever has the imposter syndrome to fix that. We need to fix that. Those of us who are in leadership roles in the field need to make the culture such that this topic is talked about freely, that we talk about it in small conversations and large conversations, and then we're open about it, and we find ways to support folks that need a little bit more push.
So the next question is, what tangible, specific recommendations do you have to improve a trainee's confidence in their technical OR skills to become less hesitant despite knowing or prepping well for the anatomy in the case? And I will just share a personal anecdote. I remember very vividly, even as a fourth and a fifth year resident, very quickly handing over the knife back to the attending, knowing that they're a better surgeon than I am. And how do you stop people from handing the knife back when, in fact, they have the ability to do what they're about to do?
I can take that one. That was exactly my problem, is I would want to hand the knife back to somebody if I felt like they could do it better. And by the nature of surgical training, the person who's training you can do better. And so you need to be willing to take that risk to take the next step. And so then this will answer some of the other questions that I know that are in the chat queue. But so my first thing I tackled was how to do a perfect circle. And I was just very incremental. I was not very good at doing a perfect circle, but I went back and I watched my fluoro and I knew what I was doing wrong. And I took each part of the perfect circle. Okay, well, is it getting the x-ray? Is it, I'm slipping whenever, I would watch the fluoro shots and it would slip back. Well, how do I stop it from slipping? Oh, well, maybe I need to drop my hand instead of raise my hand. And I made it following a recipe book. But I didn't try to go into it. I think part of the big thing there is I didn't try to go into fixation of a femur fracture. That to me is too big of a problem. I said, okay, today I'm going to get really good at doing perfect circles, or this week I'm going to get really good at perfect circles. Next week, I'm going to get really good at doing a starting point. And the week after that, I'm going to get really good at this. And before you know it, I'm really good at nailing a femur. And then I've got to find something else to do. And so that was and that still continues to be how I tackle it. And, to normalize some of the conversations too about feedback, at the end of that femoral nail, I will have them leave the fluoro still, on difficult cases, I'll have them leave the fluoro in the room. And I sit there while somebody's closing the wound and I stare at the fluoro and I just talk out loud. Well, this went well, this could have gone well. I'll just keep going through it. It's mostly for me, but it's also to normalize it for the resident who's in the room too. So that then at the end of the case, I can say, hey, what do you think we could have done better? It's a we thing, not a you thing. Because we are a team doing this surgery, and that's how I approach it. So then it just actually becomes a normal conversation. And so when the residents do a good job, I say, hey, you did a great job with this. Or when they don't do a good job with something, I'm like, hey, next time, figure out, go home and look through your fluoro shots, figure out how to do a perfect circle better. And then next time come do a perfect circle better. And so it just becomes not a thing. It's not a me telling them what to do, they're engaged in the process.
So this is a really nice question from a PGY5. Thank you so much for talking about this. As a new PGY5, I really feel like I'm behind, even though my evaluations have all been good. I didn't know anyone else may feel like this, and it wasn't just a lack of skill. My male faculty seem to give the male residents more opportunities in the OR because they seem more confident. I can be too hesitant in the OR because I am worried about making a mistake or hurting a patient. How do I work through this?
I can take that one. So that's a very common feeling. I think probably everybody in the panel can relate to that in some way. I know I can. And it just kind of gets back to much of what we've been discussing this evening, and that is identifying someone that you trust, whether it's a mentor, a more senior colleague, as a chief, maybe it's a fellow or an attending who you have some rapport with, who can give you some feedback and then honestly share with them that you're having that sentiment and that you're struggling with it. I know that when I was in training, I was concerned, what, am I as good a surgeon as the other people in my class? Maybe I'm not. How do I know? I don't really see them operate. And so it's just the same thing. And if you can identify someone to share that with, maybe they can help give you some perspective around it, because chances are you're probably performing where you should be. And if you're not, they may be able to give you some pointers as to how to improve with various technical aspects of the case. But most of the time, it's going to be a confidence problem like we've talked about. And so knowing that and working on it, and taking small steps, maybe it's just one part of the case where you're going to assert yourself or you're going to practice and then feel like, hey, I did it. It's good. And resist that urge to give the knife back until somebody says, okay, why don't you stop for a minute and I'm going to take over this part of the case. Feel like, wow, you've made some progress, and then reflect on that and use it to build your own confidence and your resilience and your ability to go back again and do it the next day. And then, at the end of the day, at the end of the week, at the end of the rotation, keep looking at your incremental progress, and that will help you to recognize how far you've come along your path. Continue to set goals for yourself and continue to push yourself, recognizing that sometimes you're not going to get there. You're not going to get all the way. But over the course of a month, a year, your residency, you're going to make a ton of progress. And if you confide in people along the way, they will give you the appropriate level of feedback to ensure that you do stay on track, and they'll help to boost your confidence most likely.
All right, I'm going to go through two more questions. We're reaching our hour here. How do you work on building your own confidence when you feel that your work is being criticized more harshly than others? So that's a culture issue. Dr. Weber, you talked about culture. I'm going to call you out on this one.
Yeah, that's one where I wish I had a little more info. And so I'm also happy to talk to whoever asked that, contact me directly. But yeah, I first think you have to get some feedback, and you can do it privately with others in your program, peers, and see if that's a valid impression. Obviously it's a perception, and so it's valid to some degree, but if you're feeling like you're being judged more harshly, but actually it doesn't appear that way to colleagues that you trust, then you got to do a little bit of work on yourself. But if that really is happening, then that is suggestion of a very poor culture. And I honestly think if this is a woman asking this, the women have to band together. This is Julie's whole thing as Ruth Jackson president. We've got to be able to help each other out. We've be able to boost each other up as rocket boosters. And I think that working with other women in the program, if you have that opportunity, it'll help gain confidence. And I think if there are attendings they're women or that are supportive of you particularly, I would start there and have some honest conversations about how you're feeling.
Great. And this is the last question for the evening, and I think it's a really important one. If you have a complication or a bad outcome, how do you deal with the confidence hit and avoid ruminating about it and letting it define your ability? And that goes to sort of the second victim phenomenon, which we've talked about before.
I can take that one. That's a very difficult one, and it's one that we have all faced. It's not pleasant, but it does get better with time. I don't have the perfect answer other than if you can identify a mentor, an advisor, a program director, a colleague, if you're a junior resident, maybe it's a chief or a fellow who you can share that with. It does help to share. I know we use the idea of debriefing after a challenging episode, whether it's, a patient complication, M&M, some other situation that came up. and having the ability to debrief and to reflect and to look for ways to do things differently and to improve. And I think that that's healthy, a catharsis of getting it out. But sometimes the environment that's set up for that to happen isn't a healthy one, and it doesn't lead itself to healing. In that case, I think you need to heal. And if you're not able to find that within your own program, oftentimes there's other resources available. There may be employee assistance program, counselors, other people where you can confidentially share some of the challenges you're facing. And it is really important to try to get that out of your system. And there are different skills that you can acquire. I know this is a really complicated issue, but it's a super important one. And developing some skills to clear your mind, to meditate, spirituality, exercise, ways to shift your focus, because it isn't healthy to internalize that. It's important that we reflect on negative experiences, that we grow from them, but we have to be able to let go, to heal, and to move on, and to recognize that we are all imperfect and that mistakes and errors will happen, and that we need to figure out how to learn from them, and we become stronger after that over time. And that maybe your path will be able to intersect with others who you can share with about how you've been able to heal and to move on, because it does get easier over time. But those are some of the strategies I might try if you're really struggling a lot.
And Catherine, this is Christy. I see you asked the question. I know Catherine, she's an excellent surgeon. And so, you know, I think the other thing is, after you've done all the things that Heather said and you're able to let it go, you gotta be nice to yourself, because you've done a ton of cases that have gone incredibly well, right? And I do think that there's some aspect of getting back on the horse there, depending on the type of case. You got to get back up there. And once you've realized what the error was or that outcome and how you can work on it better next time, you got to get out there and know that you can do that, and you can do it well.
Actually, I am selfishly going to ask another question to learn from this one, actually. So the question is, how should we as female attending surgeons address feedback or criticism that we are too hard on certain residents who may be more vulnerable to imposter syndrome or confidence issues? Should we as women be viewing those residents who have confidence issues differently?
So I think it's our job to boost them up when they need boosting, and to give them the feedback when they need the feedback to get better, and to be honest in the conversation about why and how you're doing that. I think if you open the lines of communication, that it becomes a lot easier. Sounds a lot simpler than it actually is.
I wholeheartedly agree with Mara's style. And I think that just clarifying, right now, I'm going to tell you something that's going to really challenge you, and it won't feel good, but I believe that you have the potential to do this, and I want you to grow. Frame it with what you're going to do, and then help to try to boost that person up.
Well, with that, I think it's great advice to leave on. There are still unanswered questions. All of us are reachable. We would love to talk about this more. Really appreciate people staying on, you know, to 9:17, still 137 people on. So thank you for joining us. We're eager to talk about this more, and happy to answer any further questions you have via email, cell phone, what have you. Thanks everyone for participating and coming tonight.